Hello, you are listening Dr. MEK podcast series. You are listening to the Dr. MEK series, Professional Updates for Clinicians.
A new era in resuscitation has begun. The ERC 2025 guidelines redefine how we manage cardiac arrest in and outside the hospital.
In this deep dive, we review excerpts from the European Resuscitation Council, the ERC Guidelines 2025 for Adult Advanced Life Support, published in Resuscitation.
And just a reminder, this content is for medical education only and not a substitute for institutional protocols or official ERC publications. Always refer back to the source documents.
Absolutely. So our goal today is pretty clear. We want to unpack the most significant updates for you, the clinician. We're not getting lost in the weeds, We're focusing on those practical changes, the evidence shifts, the things that will actually impact how you approach resuscitation.
Right. And what's fascinating here is just how rigorous the whole development process was. These aren't just pulled out of thin air. They build on the ILCR consensus, ERC expert groups, and importantly, a huge effort to incorporate external feedback.
Yeah, that really jumps out from the source material. I mean, something like 325 comments submitted during the public comment phase. That's significant.
It is, and it led to 66 substantial changes in the final version. That shows they were really listening to the global clinical community.
That's a huge level of engagement.
It really is. And something else new this time, a patient public representative was actually on the ALS writing group.
Oh, interesting.
Yeah, it signals this move towards more integration, shared decision-making, which actually highlights the first big thematic shift we see, really focusing on preventing in-hospital cardiac arrest, IHCA.
Right, the idea that the best ALS is the ALS you manage to avoid altogether. So how does this focus on prevention actually play out for clinicians on the ground?
Well, it really doubles down on being proactive. We see continued reinforcement for using those track and trigger systems, early warning scores, EWS, to spot critically ill patients sooner.
Okay, that makes sense.
But maybe even more importantly, it pushes for shared decision-making and advanced care planning. So resuscitation goals get integrated much earlier into the patient's overall emergency treatment plan, not just an afterthought during a crisis.
And there's a part here that feels really empowering, almost a culture shift. It's about who can call for help.
Exactly. This is huge. The guidelines explicitly state that all staff, not just nurses or doctors, but all staff are empowered to call for help based purely on their clinical concern.
Regardless of the EWS score or the vital sign.
Precisely. Independent of the numbers. It's a massive endorsement of that frontline gut feeling, that intuition, that experience. It acknowledges that sometimes people just look sick before the numbers change.
That feels like a significant step in preventing failure to rescue.
It absolutely is. It recognizes that failure often stems from delayed recognition, not a lack of intervention options. And this whole prevention focus sets the stage for the main ALS updates themselves. Compared to 2021, the big headlines are kind of amplified,
Amplified how?
Well, an even greater focus on starting ALS interventions as early as possible, a definite increased emphasis on getting effective oxygenation and ventilation breaths in alongside those high-quality chest compressions, and some new clarity on getting that apical or lateral defibrillation pad position just right.
Okay, let's jump right into that then, the defibrillation piece.
Yep.
The rule for immediate defib seems pretty straightforward now.
Oh, absolutely crystal clear. Immediate defibrillation for ventricular fibrillation, VF, of any amplitude. Doesn't matter if it looks fine. If it's VF, you shock it now.
No hesitation. And what about when that doesn't work? What about refractory VF? That's defined as VF still present after 3 shocks, right?
Correct. Continuous VF after 3 attempts. So the first step is always double check your pad placement. Is that standard anterolateral placement actually correct? Good contact.
Assuming it is, what's the next move according to the 2025 guidelines?
The new recommendation is to strongly consider a defibrillation vector change. Most commonly, this means switching to an anteroposterior placement. Put one pad on the front, one on the back.
And the thinking behind that?
The idea is to change the path the electricity takes through the heart muscle, potentially recruiting different myocardial cells that weren't depolarized by the first vector, trying to hit those stubborn refractory areas.
That seems like a practical, relatively low-risk strategy. Okay, but now we have to talk about the big one. The thing generating so much buzz, dual sequential defibrillation, DSD.
Yeah.
Using 2 defibrillators. What's the ERC's official line on that?
Yeah, DSD has gotten a lot of attention, but the ERC recommendation is pretty definitive for now. DSD is not recommended for routine use outside of a research setting.
Really? Despite the interest in ongoing trials, why so firm?
Well, the rationale comes down to a couple of things. One, The evidence for benefit just isn't conclusive yet from the studies available. And 2, there are very real practical challenges: resource use, complexity, potential safety issues with 2 machines in a stressful code situation. So they're prioritizing simplicity and known safety profiles for now. Keep it simple, keep it safe, until better evidence emerges.
Okay, that's a really important clarification for practice. Now let's switch gears slightly. Logistics. ALS arrives, and AED is already attached and maybe just shocked. What's the process?
Good question. Initially, you follow the AED's prompts. Don't interrupt its cycle. But the goal is to transition smoothly to a manual defibrillator during the next available 2-minute CPR cycle, if you can.
And the key constraint there?
Speed and skill. Manual defibrillators should only be operated by providers who are really proficient. We're talking rapid rhythm identification, like under 5 seconds, and delivering the shock with minimal interruption to compressions. Again, aiming for less than 5 seconds off the chest.
That 5-second pause keeps coming up. It's clearly a central theme.
It absolutely is. Minimizing interruptions is paramount. Which, speaking of things being minimized or removed, the precordial thump.
Ah, yes, the thump. Is it officially out?
Officially out. No longer included in the guidelines. The success rates were just too low, and with defibrillators being much more readily available, it's just not considered a useful intervention anymore.
Okay, good to know. Before we leave this section, there's a really interesting and quite humane addition about CPR-induced consciousness. That situation where the patient actually starts to wake up during compressions, even without ROSC.
Yes, it's rare, but incredibly distressing when it happens for everyone involved. The guidelines now address this directly.
How should clinicians handle that?
They suggest considering small doses of sedative or analgesic drugs, things like fentanyl or perhaps ketamine, maybe midazolam, to manage the pain and the distress. Keep the patient comfortable.
And the key restriction.
The crucial thing is, neuromuscular blocking agents, paralytics, should not be given alone just to stop the movement in a conscious patient. You must address the consciousness, the pain, the anxiety first. Treat the patient, not just the movement.
That's a really important ethical and practical point. Okay, let's move on to the plumbing and the pipes access and the airway. Vascular access first. Is there a clear preferred route?
Yes, there is. The recommendation is clear. Attempt intravenous. 4, access first. Get that peripheral line if you can.
And if you can't, what's the threshold for switching?
Intraosseous, IO, access is considered a reasonable alternative only if you can't get IV access rapidly within 2 attempts.
2 attempts. That's quite specific. Why the emphasis on trying IV first, even if IO might sometimes feel quicker in difficult patients?
It seems to be about balancing speed and potential complications. 5E is generally preferred if achievable quickly, but that 2-attempt limit is critical. If you fail twice, don't waste more time fiddling with IVs. Move straight to IO to ensure you can get drugs in promptly. Time is perfusion, right?
Makes sense. And the airway strategy, still a stepwise approach.
Still stepwise. Supraglottic airways, SGAs, are generally the initial go-to advanced airway if basic measures aren't enough. But there's a nuance now.
Which is?
If you're using an SGA, the guidelines suggest the iGel is preferred over a laryngeal tube, based on the current comparative evidence looking at ease of insertion and ventilation success.
Okay, iGel preferred for SGA. What about definitive intubation, the endotracheal tube?
The standards for attempting tracheal intubation during CPR are now set very high. It should only be attempted by rescuers with a documented high first-pass success rate. The expert consensus landed on aiming for greater than 95% success within 2 attempts overall.
Wow, 95% success rate. That's a high bar.
It is. And crucially, any attempt must minimize chest compression interruptions to less than those critical 5 seconds.
So if you don't have that proven skill level or can't guarantee minimal interruption, stick with the SGA.
Essentially, yes. Maintaining perfusion with high-quality CPR and adequate ventilation via an SGA is prioritized over a potentially prolonged or unsuccessful intubation attempt by someone less experienced. Good BLSGA beats bad ALS intubation every time.
And confirmation of tube placement, still capnography.
Absolutely non-negotiable. A sustained end-tidal CO2, ETCO2 trace on waveform capnography must be used to confirm tracheal placement and exclude esophageal intubation. If you don't see that consistent waveform and number, the tube's not in the right place, period.
Got it. Okay, let's quickly run through drug timing. Adrenaline.
Still rhythm dependent. For non-shockable rhythms, that's the systole or PEA, you give adrenaline 1 milligram as soon as you have access. Get it in quickly.
And for shockable rhythms.
For shockable rhythms VF or pulseless VT, you wait. Give the adrenaline 1 milligram after the 3rd shock has been delivered.
Okay, after the 3rd shock for shockables, ASMP for non-shockables. What about drugs we should generally avoid giving routinely?
Right, the guidelines reiterate this. Calcium, sodium bicarbonate, corticosteroids, none of these should be given routinely during cardiac arrest. There might be very specific indications like hyperkalemia for calcium, but not as a standard part of the algorithm.
And antiarrhythmics for that persistent VF or pulseless VT after the third shock.
If it persists after shock number 3, the standard first-line antiarrhythmic is still amiodarone, 300 milligrams to 30.
Any changes there?
You can give a further 150 milligram dose after the 5th shock if needed. And importantly, lidocaine is now clearly stated as an acceptable alternative if amiodarone isn't available or contraindicated. The dose is 100 milligrams IV bolus with an option for another 50 milligrams.
Okay, amiodarone first, lidocaine as a solid backup. Good clarification. This brings us towards the more advanced end of the spectrum in these guidelines, physiology-guided CPR. This sounds interesting, especially for places like the OR or ICU.
Yeah, this is a really significant development. It's moving beyond just doing CPR based on the clock, 2-minute cycles, and starting to use real-time physiological feedback to guide resuscitation efforts, particularly in those highly monitored settings.
So what are we looking at? What metrics?
Well, the guidelines suggest that clinicians should consider initiating or perhaps intensifying chest compressions if they see specific physiological warning signs. For example, a sudden significant drop in the ETCO2 level, or if the systolic blood pressure, measured invasively, persistently stays below 50 millimeters of mercury despite other interventions.
And they actually give targets now, not just do high-quality CPR.
Exactly. This is key. When you have continuous intra-arterial blood pressure monitoring, which you often do in the ICU or OR, the guidelines provide pragmatic targets to aim for during CPR.
What are those targets?
Aim for a diastolic blood pressure, the DBP, of at least 30 millimeters of mercury, and aim for an end-tidal CO2, ETCO2, of at least 25 millimeters of mercury, which is about 3.3 kilopascals.
Why those specific numbers? DBP of 30 and ETCO2 of 25?
Because they're considered the best available, easily measurable surrogates for adequate perfusion during CPR. Specifically, diastolic pressure relates strongly to coronary perfusion pressure, keeping the heart muscle itself supplied, and ETCO2 gives us a good indication of pulmonary blood flow and thus overall cardiac output generated by the compressions, reflecting cerebral perfusion to some extent.
That's a major shift towards personalized resuscitation in those settings. Does this physiological monitoring also change how drugs like adrenaline are used?
It does, quite significantly. In these continuously monitored situations, the standard 1 milligram bolus of adrenaline every 3 to 5 minutes might actually be too much or timed wrong relative to physiology.
So what's the suggestion?
The guidelines suggest considering titrated doses initially, giving smaller increments, maybe 50 to 100 micrograms IV at a time, guided by the blood pressure response.
Why the smaller doses?
The idea is to avoid that potential massive hypertensive overshoot that can sometimes happen right around the time of ROSC if you've just given a full milligram. Titrating allows for potentially smoother hemodynamic control during that critical transition phase, optimizing the chances of sustained ROSC and better neurological outcome.
Very interesting. Moving on to another advanced therapy, extracorporeal CPR, or eCPR. Still very resource intensive, right?
Extremely. But the guidelines provide a bit more definition around its potential role. It may be considered as a rescue therapy for selected adults, both in hospital and out of hospital cardiac arrest, but only when conventional CPR is clearly failing despite good execution.
And who are these selected patients? What makes someone a potential candidate?
The criteria associated with better outcomes are becoming clearer. Generally, it favors younger patients, those who had an initial shockable rhythm like VF, a witnessed arrest, and critically short low-flow times.
Low-flow time.
The time from the start of CPR until the patient is actually on the ACPR circuit getting oxygenated blood flow. Ideally, this should be less than about 45 to 60 minutes to cannulation. It really underscores that eCPR isn't a salvage for prolonged, unwitnessed arrests. It's for a very specific group where rapid intervention might bridge them to recovery or other therapies.
Okay, highly selective, rapid deployment needed. Finally, the guidelines even touch upon what happens after resuscitation attempts are unfortunately unsuccessful. They discuss uncontrolled organ donation after circulatory death, or UDCD.
Yes, the inclusion of UDCD really shows how comprehensive these guidelines aim to be, considering the entire pathway, even end-of-life options were appropriate. This is obviously only relevant in healthcare systems and regions with established UDCD programs.
And what does that process involve, briefly?
Well, after the formal decision to terminate resuscitation efforts has been made, if the patient is potentially eligible for UDCD according to local protocols, it requires continuing CPR, specifically chest compressions, during transport to maintain organ perfusion, particularly for kidneys and liver. Then, there's a mandatory no-touch period, usually about 5 minutes after all resuscitation efforts have definitively stopped, just to absolutely confirm circulatory arrest and rule out any chance of auto-resuscitation before the organ recovery process can begin.
That's a complex but important consideration to include, right? That covers a huge amount of ground. If you had to distill it down, what's the single biggest theme or takeaway from these 2025 ERC ALS guidelines for the practicing clinician?
I think it's the emphasis on maybe balanced excellence. They managed to absolutely hammer home the critical importance of the basics, high-quality compressions with minimal interruption, early defibrillation, effective ventilation. These fundamentals are non-negotiable. But at the same time, they're clearly opening the door to more sophisticated, physiology-driven decision-making, especially where monitoring allows it. And they're broadening the scope to include prevention before the arrest and sensitive end-of-life pathways like UDCD after. It's about optimizing care across that entire spectrum.
You are listening to the Dr. MEK series. Stay current, stay prepared.
It leaves you thinking, doesn't it? As technology gets better, as we can literally see things like diastolic blood pressure and continuous ETCO2 during a code in more settings, how is that going to change our real-time definition of refractory arrest? And maybe more importantly, how quickly can we realistically integrate these more advanced, personalized physiological strategies into routine practice outside of the specialized ICU or OR environment? That feels like the next frontier.
Remember to subscribe and hit the bell icon for future emergency medicine updates. Thank you for advancing resuscitation science with us.